Hello, everyone. Thank you for joining us for Setting Postoperative Expectations with some case examples. My name is Melissa Warwick, and I'm the Manager of Medical Education and Professional Relations here at AcuFocus. Today we are going to be going over a series of cases and talking you through what to look for and how to talk to your patients. We have joining us today Dr. Sandra Black and Dr. Eris Jordan. Dr. Sandra Black, many of you may know her, and if you've joined us for other clinical webinars, you may have heard her previously. She is the clinical director at Crystal Clear Vision in Toronto. She is also a camera inlay patient, so she can speak on behalf of a patient and as an optometrist in a practice. So she is a great resource for us. Thank you, Sandra, for joining us today. And I'd also like to introduce Dr. Eris Jordan. Dr. Jordan has been a part of AcuFocus on our training team as a clinical specialist for a little over a year and a half and may have already been into one of your clinics. So thank you, ladies, for joining us. And again, everybody is on mute, so if you have any questions, please enter them in the chat box and we'll make sure to address them. Dr. Black, would you like to take it from here?
Thanks, Melissa. Good to be here again. I think that one of the first things that we always have to make sure that we do is set the proper expectations for those camera patients. It's definitely different than LASIK, and for those of us that have been involved in refractive surgery for a long period of time, we're used to the patient the next day being able to see and being extremely happy. Well, this is not like LASIK. This is definitely a much slower heal. And we have to make sure that when we talk to the patient beforehand, when we're in our consultation, that we actually address this before so that they fully expect that this is going to be something that is going to take some time. But having said that, you know, we do get the occasional patient that's just not happy and that we have to deal with. So what we've done is we've kind of laid out all the possible solutions to dealing with that unhappy patient, and we put them in the order of the frequency. And you can see that, you know, the number one thing is optimizing that tear film, and what you are going to find is that that's going to be the number one thing that you're going to be dealing with post-op, is making sure that you address that dry eye and optimize that tear film to get a good result at the end of the day. Next slide. So I think the first thing that we want to go through is what's the norm with this? What is the norm with your average patient? And like I said earlier, it is definitely not that day one, oh my God, I can read for the majority of patients. And if you look at this patient, which is your basic normal healer, what you'll see is the refraction is perfect, and the centration is great. You can see it at the bottom. It's well within that 300 microns of where you want to be. But you can see that the distance vision is not where you want it to be. It's 20/50 at the 1 week mark. It's J5 with the reading. And you look at the scatter, the optical scatter, you can see it's a little bit on the high side, not horrible, but a little bit high. And you can see all those fluctuations on the tear film. So you want to look at all this data. But you can see that as things progress over the first few months, slowly but surely, the reading is getting better. The distance is getting better, and you can see at the same time the OSI, or that optical scatter, is decreasing, and the tear film is optimizing and getting better. And so this is that normal patient, which takes about 3 months. Next slide. And then you've got your fast healer, and I go through this in the clinic all the time because when I had my surgery done, 4 years ago, it took me 6 weeks before I was able to see properly, and I lived through this little fog and I dealt with it. But when Jeff, the surgeon that I work with, when he had his surgery done, and he'll be 5 years in August, he read the next day. He was absolutely perfect, and unfortunately we had this on a tape. He was videotaped reading the next day. We were in Tokyo to get his eye done, and he was reading all the small print day one, and that's on the front page of our website. So patients come in going, hey, I saw Dr. Machat reading the next day, and this is what they expect. So what we always say to patients is there are a small percentage of patients, and we say about 20%, that will actually be able to read the next day that are very, very fast healers, but 80% of patients are a longer, slower heal that will take anywhere from 6 weeks to 3 months. And we always use me as an example, that I took a few months to heal, and that is norm. So if you look at this patient, and it's usually males that I found in my personal experience. I don't know, Eris, if you're the same, but males tend to heal faster than women for some reason. I'm sure it's tear film.
I agree.
Yeah, it's some weird thing with guys, I don't know. But anyways, and if you go on to the next slide, you're also going to get something that is totally normal, but it can take a patient up to 6 months. So if you look at that patient and you see that the refraction is normal, you see that the inlay is centered properly, but you do see a higher scatter and you do see some fluctuations in the tear film, don't automatically assume that this is going to be a patient that isn't going to do well. For these patients, it just takes some time to actually optimize that tear film, get rid of all the edema, because don't forget, you're looking through a pinhole, and whenever you look through a pinhole, if there's any dry areas there or any areas of edema, you have nowhere else to look around. It really affects the outcome and the visual acuity. So if everything else looks normal, don't abandon that patient and assume they're not going to be successful. Wait it out, use lots of artificial tears, use Restasis, punctal plugs, anything you need to do to just get that patient happy and just stick with it and spend a lot of time with reassurance. Anything you want to add to that, Eris, that I missed in there?
No, I think it's perfect, and really good points about expectations. I find that whenever I hear from clinics on the back end that this is just taking up so much chair time post-operatively, I always think perhaps the expectations were not set properly on the front end. And you're absolutely right in that a lot of these patients have LASIK as a baseline of how visual recovery is going to be for them. And for me, Sandra, I don't know if you agree with this approach, but usually, for PRK patients, the healing time is just much slower. So when I set the expectations for the clinic of how to manage these patients and set expectations for the patients, I usually say, assume sort of like PRK healing time, but obviously without the pain of the PRK. So,
yeah, I think that's a great analogy, and it's all that under-promise and over-deliver, because then if they're a fast healer, they love you to death and they think you're fantastic. And if they're a slow healer, then this is what you told them. This is the norm.
Well, that's the other thing I was going to say is you have the psychology of it all is that you have to celebrate with the patients when they're, ahead of the curve, and generally they will rely on you to just encourage them that they're doing okay. So that's a great point.
I'm handing this over to you now.
No problem. So, assuming that the expectations have been set properly, like Sandra, you were saying, is that occasionally you will get a patient that is coming in and despite having the proper expectations, they will be displeased with their vision at some point during their healing process. So we'll go back to this list of differentials because we want you to think about, as we approach the cases, about what possibly could be the culprit for the patient's suboptimal outcome or their the reason for being displeased with their vision. So in the second case, you will see that, this is a 52-year-old female with no improvement of vision at 1 month. And we've cheated a little here and highlighted the pertinent information. But the thing that I want to bring your attention to is that I want you to note the refractive target is aligned with our recommendations, which is at -75. And you will see that it is remaining the same at each consecutive visit. The second thing that you will see is that the OSI and the tear film appear unremarkable. Oops, gave our answer away there. So the one thing, that you should also look at is that the pre-op Purkinje within our 300 recommended microns. So at this point, we would aim for centration of the inlay to be on the first Purkinje. So, at this point, everything looks pretty good, yet the patient does not have any improvement in their near acuity, and their distance acuity has post-op dropped to 20/50, and it remains at 20/50. So if you have, an idea of what the culprit of the decreased acuity is, you can enter it in the comment section. But for me here, and Sandra, feel free to chime in, the telling piece is that both the distance and the near acuity remain unchanged during the healing period with no changes to the MR. with a normal tear film. So, at this point, next slide.
Yeah, you're right in that the tear film looks totally normal there, and so does the OSI. So everything else is kind of like going, okay, something's going on.
Yeah, and so at this point, exactly that, I would start honing into in on the centration. At this point, our recommendations is that you should consider recentration should the inlay be, within 300 microns of intended target. So that said, the patient will be the most, will tell the most conclusive story as, whether we should rectify their suboptimal outcome. So even if you have a decentered inlay that looks decentered on AccuTarget, really hear what the patient has to say and whether they're symptomatic. So here, the inlay is actually decentered superiorly, and you can see that with relationship to the Purkinje. And I want to pause here for a second because I want to discuss tolerance of displacement with the patient. So from our experience, numbers aside, we have noticed that patients will be least tolerant of a superior displacement, followed by a temporal displacement, then nasal, and then the least or the most tolerant of an inferior displacement. So to simplify it, I always pause on a post-op scan that has a large positive value on either the X or the Y axis, because that's indicative of a temporal or a superior displacement, and that more than likely may affect the patient. So, Sandra, anything to add there?
Well, you know what I totally agree that superior is the worst. They just don't tolerate that at all. Even if it's within the 300 microns of tolerance, they just don't do that as well. But one thing I've found with a couple that we've had to recenter is if I say to the patient, when you notice at night, when you look through that inlay eye at night and you look at a street light, is the glare symmetrical? And if the patient says to me, you know what, I see all the glare out of the bottom part of the inlay, like I see just all the glare is at the bottom and the top is fine, then that's telling me that they're actually looking through those micro perforations as opposed to the center of the inlay, and it's off center. So I use that a lot now, and that's something new I've just started using, is just asking the patients what their visual symptoms are at night.
Yeah, I love that because it's very true. And, sometimes they cannot even verbalize it. They know it's blurry and something's not right, but calling attention to that, I think, is really smart. I think I'll start doing that from now on. All right, next slide. So here you will see that, so after recentration, you will see that the vision in this particular case improved drastically, and you will see that, those post-op values are actually in the minus now. So minus, regardless of which eye, is inferior and nasal. So obviously, always take the cues from the patient here. They will definitely tell you whether it's affecting their vision or not, regardless of what those values show. And, a little bit of the point also to make with regards to where that inlay is decentered. If it's a superior decentration, I would wait probably 4 to 6 weeks before you intervene surgically and reposition the inlay. If it's an inferior decentration, you can wait probably about 3 months because the patient actually may neuroadapt. And the reason why is because, our eyes just naturally drift infranasal when we're reading. So that kind of corresponds with the location of the fovea. So the patient may be more tolerant of it, although it is a large negative value like you see in the next slide. And Sandra, anything to add to that?
Yeah, totally. I've seen patients where I look at them and I think, wow, I'm shocked at how well they're seeing, and they've got that inferior decentration. And also, I think another thing that's really important that we like to make sure that our optometric network really understands is that the inlay will not look centered at the slit lamp. So it's amazing how often at the beginning we had a patient that was totally happy, but the optometrist would look at them through the slit lamp and go, oh, it's decentered, and send them back to us, and then all of a sudden the patient starts to get worried, where before that they were totally happy. So it's really important to educate your optometric network on that as well, if you're co-managing, that they do not look centered at the slit lamp, because it is not a coaxial microscope.
That's also a good point. Yeah, so I think that's it for the recentration. You know, this very last slide will show you a large value on the y-axis. However, it has that negative value to it, which means it's an inferior displacement, and this is the one case where I would certainly keep an eye on this patient, keep an eye on whether they have any symptoms that they're complaining of, and if so, then I would wait generally about 3 months before I consider any recentration. So Sandra, I'll throw it back to you here.
So we're back to that same list again about all the things that you're going to be looking for, and we're going to go into the next case. So if we go into the next slide. So if you look at this case, this is a patient who healed very quickly. You know, 1 week they were already 20/20 in J2, and they maintained that really well over the first 3 months. But what you can see is that at 6 months, all of a sudden there's a change. All of a sudden the patient has lost their distance. Well, it's not, they're 20/25, but they're certainly not 20/20 anymore. But they've definitely lost their near, and they're now refracting out at plus 0.75. And if you look at the OSI, you can see that there's also a little bit more scatter. And I think that, you know, when this patient first presents, you've really got two possibilities of what this could be. One could be something as simple as this patient was hyperopic. You did a LASIK on them at the same time as you did the inlay, and now they've regressed back to that, you know, hyperopic state. But you have to look at that scatter and say, well, the scatter's gone up, so there must be something else going on there that's not just refractive. And if you go into the next slide, that when you see a hyperopic shift, so you see that patient going from being myopic to being hyperopic, you have to rule out haze. And basically what this is it's a wound healing response where the body is essentially trying to encapsulate the inlay and trying to reject it. It's like getting a sliver and, you know, your body trying to bring it up to the surface. So that's what this is doing. So what you'll notice with these patients is you'll notice, you know, this fuzzy haze around the inlay. Sometimes it's the edge, sometimes it's underneath, sometimes it's on top. And you'll definitely notice on topography more of a red ring, and that's very typical of a patient that has had this wound healing response and is developing haze. Next slide. So what you're going to want to do is you're going to want to immediately start them back on a steroid. And you want to start them back on a strong steroid. So, you know, we start all our patients on Predfort, and we go into QID, and then we see them back in a couple weeks. And what you're going to find is that if they're going to respond to this, they respond very, very fast. So you'll see at 2 weeks whether all of a sudden their haze may not be totally gone, but they should be creeping back down towards myopia. Their vision should be improving, and it's a very, very fast response. And that happens the majority of the time. So, you know, about 75% of the time, you're going to find that this works, boom, they're on the right course. And then what you're going to want to do is you're going to want to go back to that weaker steroid and just taper it off slowly and monitor them. If you don't see any shifts back to myopia, if you find that they're still exactly the same, their vision's still the same as it was, they're still hyperopic, and there's absolutely no shift, that's a patient that likely will not respond to the steroids, and you're probably going to want to think about explanting that inlay. Next slide. So really what you want to do is you're going to be following kind of a checklist. So the first thing that you're going to look for is, did it resolve? If it resolved, then, and it stays like that, so they stay on their shift of their course of the inlay, of the steroid, sorry, and their myopia stays and their vision stays, then you're in good shape. Some of those patients they'll go towards myopia. They may not go right away to their original target, but they'll go, you know, the hyperopia will start to disappear. And they don't have any symptoms, they're a lot happier, then what you're going to want to do with those patients is just keep them on that steroid regime and just watch them, just monitor them. And for the most part, they should stay and they should be happy, and that should be the end of what you have to do with them, and they're back to being a happy patient again. But there are going to be some patients that you will put them on that Predfort, they will seem to resolve, they will go back to myopia, And then as you go on that weaker steroid and you go down to that taper, it's going to rebound back again, so they'll be back in your chair, you know, a few months later with the same complaints all over again. Or you're going to have those patients that they rebound a little bit. In other words, they get most of the hyperopia goes away, but they don't go fully into their original myopic correction. But they're still complaining. They're still not happy with the quality of their vision, and the steroid regime just isn't working well for them. So for this group of patients, you're going to want to consider taking that inlay out. It's a very small percentage. We've probably removed 2 to 3% of our patients. We've had to remove the inlay. And a few of them, we've actually just let them heal out, and then we put back in a new inlay. We've had them come back in and redo surgery again after everything's settled down and gotten them back into another inlay, and they've been happy. Have you noticed anything else like from this, Eris?
No, I think this is great. I mean, honestly, what I've noticed is that the incidence of wound healing responses and what I've seen in clinic has really decreased quite a bit since we've gone to a deeper implantation with, you know, a 250 or deeper if the cornea allows. So thankfully, we're not running into this issue all that much anymore. But two quick comments I actually wanted to make about wound healing is, and correct me or let me know what your experience has been, Sandra, but what I noticed with regards to sort of like the chronology of the wound healing is that a patient will essentially come in and will notice a change in a pattern of acuity. So the patient has been trending better, and then all of a sudden they sort of turn the corner and, you know, they were 20/30, 20/30, 20/25, and they come in, they're 20/50. So that's sort of like the first thing that I noticed changing with the wound healing. And then, you know, you obviously confirm it with some sort of haze on slit lamp. Then I will see some OCT changes when we do an anterior segment OCT. And then when I see a topography change, generally it's more to a moderate and severe level. So if a clinic is going to a topography, and the topography may look entirely normal, but if the rest of the you know, the picture is just not looking like something is right there, I definitely think that you need to kind of dig a little deeper.
Yeah, totally agree with that, because sometimes there actually is haze there, but it's actually underneath the inlay, and you can't really see it. It's difficult to see.
Yeah, that's a good point, and an OCT will do a nice job at catching that, you know, any haze underneath, because it'll show as a little bit of thickening either above or under the inlay. So if you have access to it, I think an anterior segment OCT for wound healing response, or just a routine follow-up diagnostic test to add, I think is a good thing to do. And one very last comment here is that I've been actually encouraging our clinics that they bring the patient in one more time after they stop the steroids. I know that, you know, we say 3 months and then the next follow-up be in 6 months, but if you're going to have any rebound from tapering the steroid, I think it's really important, if you can, bring the patient in at a 4-month mark so you can see what they look like after 1 month off of the steroids.
Yeah, no, that makes total sense.
So once again, you know, sort of crossing off off of this list of what is, you know, the culprit for some of these patients coming in not being entirely thrilled, the next scenario you'll see that this patient, you know, if you're looking at the near acuities, they consecutively have improved. The one thing that I actually want to highlight, actually 2 things there, is notice that the distance acuity is pretty good. They had good distance that was unaffected right from the beginning, and then all of a sudden we see a little bit of a shift toward the 6-month mark. The patient drops to 20/60. The one thing that we did highlight is the tear film, but more importantly, I actually want to call your attention to the manifest refraction. And what you'll see there is that we started with our intended target of -3/4, and you'll see a little bit of a myopic shift there, which corresponds with the patient's acuity. So, you know, whereas with a wound healing response, you'll see more of a hyperopic shift in a case like this that has more of a myopic shift, you would be a little bit more suspicious of dry eye and any surface issues. So As you're looking at the tear film, that seems to be conclusive of dryness because you see that the OSI and the standard deviation following it starts at a low, and then at the 6-month mark it actually increases corresponding with the manifest refraction in the patient's acuity. Next slide. So here on the orb scan, or on the topography, what you'll see is a blue ring versus the red ring on the wound healing. And the other thing is you'll see that on the tear film, you will have an erratic and elevated tear film. So it all, all signs sort of point to dry eye here. Next slide. So when you set expectations for the patient, just realize that, no patient is ever alike and no cornea is ever alike. So dryness is something that definitely affects the patient. And, dryness over a 4 millimeter pupil is much better tolerated than dryness over a 1.6 millimeter pupil. So it's very, very important that we optimize the surface. And, what I like to do normally is I look at the patient as a puzzle composed of, sort of multiple pieces. And I don't ever recommend that you hang your hat on just one finding. So, although the MR may seem to correspond with the tear film here, this could be a case of LASIK regression. So if the surface looks quiet on slit lamp, the tear film is looking pretty good, yet you see that there is a myopic shift on the patient, and the distance consecutively becomes worse, then certainly don't rule out a regression, although that could be, more of a rare finding. So with regards to the dry therapy, our recommendations are what they've always been, which is the pre-op, either temporary or permanent plug. The nice thing about the collagen plugs is they tend to dissolve over a 3-month period, which sort of goes hand in hand with the drops and also that neuroadaptation period for the patient. Use artificial tears, omega-3 fatty acids, and then Restasis and Xiidra. So anything to add to that, Sandra?
Well, I'll tell you, I totally agree with all that. We put in a temporary collagen plug on surgery day on all of our patients, all of our camera patients. That's just automatic. And I put probably 85% of my patients pre-op on Restasis regardless of what their tear film looks like, especially the females, because every female in their 50s, has some type of dry eye. And so we try and deal with that beforehand. And what I did find, and I totally agree with this slide, in that, they always say when you talk to Allergan, they say that Restasis doesn't start to work for at least 6 weeks, up to about 3 months. When I tried it on myself, it worked in about 2 weeks. I noticed a significant jump in my vision. And you'll see this in camera patients, in all the camera patients, is that you get a jump in their tear film, and it's just so much clearer for them fairly quickly after going on Restasis.
What I've seen with Xiidra is that, and this may be variable, but it works, pretty quickly. And in a lot of patients, actually, that have been struggling with moderate to severe dry eye, either pre or post-op, a combination of both has actually been very effective as well. So as long as that surface is well managed, I think, you should have a pretty good outcome post-operatively. Okay, back to you, Sandra.
Back to me. Okay, so we're going to keep going through this list, and we're going to go on to the next case. So this is a patient that if you look at, where they were beforehand, uncorrected, the distance vision was 20/20. Obviously, they couldn't read because she's presbyopic, but her refraction is +1/4. And, we all know that even though in the FDA trials they enrolled patients that were +0.5 to -75, a lot of us have difficulty with the thought process of actually doing a refractive procedure, a LASIK procedure, on a mildly hyperopic eye, even because their uncorrected vision is 20/20. So, we've had the same scenario here where we've taken a patient that's +1/4 and said, okay, let's just put the inlay in and let's see where you end up. And you can see that this patient, is not doing as well as they would want to. J3 just doesn't cut it for most patients. They usually want a little bit more up close. And if you rule out everything else and you look at centration, you look at tear film, you look at the OSI, you can see that all of those are normal. So what you're going to have to, at one point down the road, deal with this patient is making them myopic, okay, getting rid of that plus a quarter, because we all know that that patient that's minus 0.75 to minus 1 refractively is going to do the best up close. So if you have that patient that you actually have just put in that inlay because they were uncorrected 20/20 and they're just not getting the results that what you want, then what you have to consider is doing a PRK enhancement to get them to that minus endpoint. And you can't do LASIK. Once that inlay is in place, you cannot do LASIK because the femtosecond laser is going to fry the inlay. So your only option is a surface procedure. So you're going to want to do PRK on this patient, get rid of that plus a quarter and make them minus 75. And I think on the next slide you've got the result, right? So here you go. So the patient after the PRK enhancement was already J2 plus and 20/20. So once you get rid of that little bit of hyperopia, even though it seems like nothing, it makes a huge difference in the outcomes at the end of the day. And so don't be afraid to take that patient and do a refractive procedure to get them to be myopic pre-op, because they'd much rather go through a LASIK at the beginning than go through PRK afterwards. Any comments?
Yeah, no, I think that's perfect. The other thing is, you know, just keep an eye on the fellow eye as well. So make sure that there's no regression of that eye. If there's any latency or hyperopia, the fellow eye needs to be addressed as well. And you know, sort of our secret refractive recipe there is plano in the dominant eye minus 75 and in the non-dominant eye. So that's once again circling back to the expectations. Even if patient is just a little bit hyperopic and it's sort of a foreign concept of both the surgeon and the patient to grasp, it's just important for them to know that ultimately they will have a better outcome as a result.
Yeah, and I think if you pinhole that patient, if you use a pinhole and you show them what they're going to be able to read with that, you know, plus a quarter, and then you add, you know, that another plus 1 to simulate the minus 75, they'll notice such a huge jump in their reading. It's a lot easier to move down that path when you show it to them.
Yeah, that's a great point. So question for you, Sandra, if you know, that first round of patients that, you know, essentially we did treat some plano patients or some mildly hyperopic ones. With regards to an enhancement, you know, I generally say wait at least 6 months after the inlay has been implanted to even consider a touch-up on that patient. What are you guys doing in your clinic?
Yeah, I totally agree that you want to give it a little bit of time because they may adapt, but you can tell pretty quickly by the 3-month mark, you know, when you dread them coming in because you know they're miserable, you know that that's the path you're going to go down.
Yeah, exactly. Yeah, I think the only reason why it behooves us to wait a little bit is if they're essentially having maybe a little bit of a hyperopic shift due to some mild wound healing response. You don't want to treat, you know, an inflammation being the culprit versus latency in prescription. So no, that's all good. Yeah. So with regards to the next slide, you know, this is once again, it's important for us to look at the patient in total and address any pathology, any ocular pathology that the patient may have. And, you know, normally what I say to the clinics and the surgeon is that if it will preclude a patient from having LASIK, it should preclude them from having camera as well. But there's a couple of things that may affect camera a little bit more, and we talked about dry eye already. Cataract is an important thing to also mention here, is because cataract formation, you know, once you drop down the pupil size to the centralmost point, any changes, any nuclear changes will actually be quite noticeable to the patient. So it's important that, you know, any patient that has some mild cataract formation in the beginning, I would actually discourage you from proceeding with camera on those patients. And do you guys follow the same protocol in your clinic, Sandra?
Oh, for sure. We got burned on one of our first dozen patients where the patient was best corrected to 20/20. We looked at the lens and I said to Jeff, there's this tiny little vacuole here. Do you think this is going to make a difference? And he said, nah, that's nothing. The patient will be fine. And we put that inlay in and the patient's vision dropped to 2400.
Yeah.
Because it was right in the center of that, that 1.6 millimeter zone. So inevitably we ended up taking out the inlay and, letting that be. He ended up doing cataract surgery about a year later. But
yeah,
those little tiny lens changes.
All right. I'm okay taking the conservative approach there when it comes to cataracts. And, I've seen it a couple of times too where, we're a little fooled even on the OSI that it's not anything that's significant. We look at the slit lamp, yet after implantation the patient is kind of struggling with it. So the other couple of things with regards to cataract is, like I said, make sure that you hone in on the dominant eye as well, even if, generally cataracts generally tend to be pretty symmetric, but sometimes they're not. So even if the inlay eye is perfectly fine, any cataract formation, any change there may impact binocular acuity. And then finally, keep an eye on those patients that are on prolonged steroid therapy. If you have a wound healer that you're keeping on steroids a little bit longer, just watch out for cataract formation there as well.
Mm-hmm. Yeah, totally agree. It's interesting that we do tend to focus on that inlay eye and then we forget about the other eye.
Mm-hmm.
And vision is a binocular system.
Correct, yeah. And, I think that's all I have for this slide.
One other quick thing that I just thought of as
mm-hmm.
well is I think you also have to be aware that if you've got these patients on long-term steroids, check their pressures. Because, you may have a steroid responder there and their pressure is spiking, it's affecting their vision, and you're wondering why nothing's getting better when they're on this steroid.
That's a great point. So just in the last couple of months, I've seen a couple of patients that were steroid responders, and we didn't know they actually came back in the clinic because their acuity had dropped. And I don't know if it was a function of maybe some microcystic edema due to the pressure, but also keep an eye that if the patient is trending in one direction and the vision drops, it's just probably another differential to add to that list. That's a great point.
Thank you very much, ladies. That was awesome. I think you guys answered everybody's questions that are on the call because we didn't get any sent in. But I want to thank everybody for attending today. And as you can see, there's email addresses for both Dr. Black and Dr. Jordan if anybody has any additional questions. Once they think about it a little bit more after the webinar or go back to the recording, this will be posted available on our YouTube channel within the next week. Oh, sorry. We did get a question. Thank you. Let me pull this up. Oh, sorry. What recommendations might you have for patients using readers daily after implantation of the inlay?
Well, I know we tell patients to avoid them. I'll say to a patient, I really need you to neuroadapt. I really need you to not get used to wearing reading glasses. But definitely if the patient is a slower healer and they just can't work, then I will say to them, you can wear them when you're at work as needed, but I need you at home to start practicing using your eyes without any glasses. I just need you to do some work, do some reading without anything.
Okay, we also know the patient has some days where the focus and up-close vision is good, some days not. They suspect the patient does not have enough patience to allow adaptation. They encourage, and encourage, but do you have any additional suggestions?
Well, I normally will say taper off readers like you taper off steroid. So, generally what I will tell the patients is that they like their readers because they're magnifying things. They're not necessarily clarifying things. So it's just, it's promoting laziness of the optical system. So I'm okay with sort of like a 2-week period where they drop down to like a 1 or a 1 1/4. And then I will challenge the patient because the other thing, in setting expectations to the patient, you have to hold them accountable for their part in it as well. Because once surgery is over, the majority of the maintenance falls on their shoulders. And aside from just taking the drops, using the readers is also their responsibility, and just sort of making sure that they're pushing themselves and using proper lighting when that's available.
Great, thank you. I'll just open it up again. They say thank you as well. To any additional questions? Do either of you have any additional final words that you would like to make? It was a very thorough presentation and appreciate it. I appreciate both of your time today as well.
No, I think that you know, we spent this whole kind of 40 minutes talking about post-operative problems, and what we have to realize, though, is that the majority of patients are very happy. This is only in a small percentage of patients that you're dealing with some of these post-op issues.
Right, great point.
Yeah, I like ending on a happy note for sure. The majority of the patients are doing great.
Happy, yeah.
Yeah, and it goes, honestly, it goes back to setting expectations, and it's good that we had this webinar, because I think that it's important. If the patient really understands the process, they will be much happier and much more patient post-operatively.
Yeah, totally.
Yep, great. Well, we'll go ahead and wrap it up. Like I said, the recording will be available within the week. And thank everyone for joining us today. And thank you, Sandra, and thank you, Eris, very much.
Thanks for having us.
Thanks, Melissa.
Thanks. Have a great day.
Bye.